We will start taking questions now. Can I just ask all the panelists to unmute and put their videos on, please? Thank you very much. We have got quite a few questions, and I'll try and go through as many as possible. I think we've got about half an hour to do this. Firstly, as you know, we have got Dr. Yadav, who is one of our senior surgeons. I was wondering what his thoughts were on all of this echo business, because sometimes surgeons can be a bit sort of, blasé about it. What does he think? And especially the newfangled epicardial echocardiography. So I would like to know your views, sir.
Well, thanks a lot. I mean, all I can say, wow, it's been one of the better webinars I've attended in the last 6 months. And when you said surgeons are a bit, whatever that euphemism you used, well, I don't agree with that. We surgeons are suitably chastised that we are nothing without an echocardiographer. And in fact, we very often quote that landmark paper by Kinhara et al. I think it was 8-10 years back, when it showed that on sternotomy, roughly 4% of patients develop a regional wall motion abnormality, which a surgeon doesn't pick up, and it's picked up on a transesophageal echo. Almost 11% have pathologies, which again the surgeon doesn't pick up, an intimal tear or a valve leak or some such thing. And in 6%, these affect the decision. That is, they inform the decision. You either put in an intra-aortic balloon pump, or you revise a graft, or you repair a valve, or do something. So please, at least with most of us, I would say in our hospital, echocardiographer is super uno.
Thank you. Do you do epicardial echo, sir?
Yes, we do. We do epicardial echo, because we do have a transesophageal dedicated machine, but we are not putting transesophageal probe routinely in all cases. We will put it in a mitral valve repair. We will put it in a left to right shunt when we are repairing, not an ASD probably, but tetralogy we would. But epicardial echocardiography, especially for smaller babies, we do use very frequently.
Thank you. And I would like to invite some of the panelists to ask the speakers any questions first, whilst I just, Sanjuni and I could basically go through some of the questions that have been asked. So please feel.
Can I ask one? Dr. Jose?
Yes.
Dr. Jose, yeah, this is for you.
Yes, please.
Sure. You talked fantastic lectures and beautiful videos, especially comparing yourself and the patient. Congratulations for that. My question is, you talked about using your ultrasound, lung ultrasound for intubation. Do you have any algorithm where you, for very difficult intubations, you routinely use this ultrasound?
If I'm in doubt.
Are there any guidelines where you can use the ultrasound for very difficult intubation?
Yeah, the question is, would ultrasound help in an expected difficult intubation? That's what you're asking. Yeah. Yes. So I think it is a sensible idea to keep the machine switched on, booted up by the side if you really expect problem. Even otherwise, if I have a machine handy, I would keep it by the side. And as I mentioned, there is no better confirmation than to see the pleural slide. It actually means the lung is expanding where you place your probe. So it 100% confirms to you that the tube is in the right place. That is one. And secondly, as I said, if you place a probe over the trachea, if you're in doubt, if you see a double trachea, two tracheae lying side by side, that indicates your tube is down the wrong hole. It is in the esophagus, and it's time that you pull it out. But as I mentioned, although we use capnography routinely in most patients, especially when you expect difficulties, ultrasound can give you first-hand information. What you do is the operator or the person who intubates carries out the intubation, and you stand by the side of the patient with the probe below the chest. And as soon as you pass the tube, you start ventilating, and then you look for the slide on either side. It is like using a stethoscope, but unlike the stethoscope, which is a very subjective feeling, ultrasound, you can see the lung move, and that is real confirmation.
Okay, thank you.
Thanks.
Mahesh, I just ask one question which is related to this topic. Anita wants to know from Dr. Jose, is there any method to know the depth of endotracheal tube by USG? How
You
much
mean
has
to
reached?
identify?
Or gone in?
Yes.
You have told.
Yeah, you cannot see the tip of the tube on ultrasound. It is not possible to see because it will obviously lie below the sternum. Unless the tube is actually well above the usual position, you won't be able to visualize the tip, if it is in the right place, that is. But indirectly, you get evidence from expansion of both the lungs. But you cannot really see the tip of the tube. There is a technique that is described, which we do not use, I haven't used myself, is to inflate the tube, inflate the cuff with water, and thereby it might help you to identify the tip better because a water-filled cuff will be more easy to see from the neck. But as I said, we don't have any experience with that. So generally speaking, you go by expansion of both the lungs adequately. You cannot see the tip of the tube on ultrasound because it is behind the sternum.
Okay, another question for Dr. Chacko. This is from Abhijit Shitole. So he's asking, for lung pulse and lung point visualization, is M mode better or 2D better?
No, definitely. Sorry, definitely 2D mode or B mode is much better to appreciate lung point or lung pulse. Lung point, as I mentioned, is the junction between the pleura that slides versus the pleura that does not slide, which you can see only on the B mode or 2D mode. You see the barcode sign on the M mode, which is just a reflection of the B mode. So what you actually need to see is the B mode or 2D mode. And the same with lung pulse as well. Lung pulse is seen when the lung is collapsed down. There is no pleural movement. The lung itself lies still, but there will be reflection of the cardiac pulsations on the lung, and it will seem to move with each heartbeat. And that suggests that the lung is collapsed down. Normally, if the lung is moving with breathing, you will not appreciate this pulsation because the pulsation will not be very much visible when it is actually moving from side to side. But if the lung is collapsed, there will be no side-to-side movement, but you'll see it pulsate. So both these are seen better on the 2D mode or B mode and not the M mode.
And another question from Dr. Sulakshana Tripathi, can M mode help in distinguishing static versus dynamic air bronchograms?
No, again, the answer is no. This is seen only on the B mode. As you saw on the slides, a dynamic air bronchogram is when you see air moving in a streaky fashion. With each breath, it moves back and forth along the bronchi. And that is a typical sign of consolidation. In static air bronchogram, you see the streaks of air, but they don't move with breathing, only because the distal air, the distal bronchi are blocked. There is no movement. The air inside the bronchi are static in a collapsed lung. So you won't see the air move back and forth. However, in consolidation, assuming there is no obstruction, the air will move back and forth, and that constitutes a dynamic air bronchogram. So that's the difference. And you see it only on the B mode, not on the M mode.
Thank you very much. Dr. Nanda, would you like to ask another question? From
any of the panelists would like to ask someone or contribute to the knowledge?
Good evening. I'm Dr. Unnikrishnan from Sri Chitra. I would like to give a comment. Dr. Jose Jago sir, it was an excellent presentation. In Chitra, we uses lung ultrasound, especially in pediatric cardiac side, and in adult side, I found it very useful, especially when you are placing a double lumen tube. We can easily check the isolation, whether the can be checked with the lung ultrasound. That is one advantage I have seen, and it has. I have one query about how the lung ultrasound is, whether it is useful in a difficult weaning patient, whether patient is, we are giving a spontaneous breathing trial, whether lung ultrasound has got any predictive value, whether this patient will succeed extubation or failure extubation. Does it have any role in that?
There are several things that you can look at in a patient who's difficult to wean and who repeatedly fails weaning. One, of course, is pulmonary edema due to systolic dysfunction or even diastolic dysfunction. You can check systolic function, diastolic function with echocardiography and look for B lines, which, as I mentioned, can be a problem in patients once they start breathing spontaneously at low levels of support. You may get pulmonary edema, that's easily seen. And secondly, even more important is to look for diaphragmatic function. As you know, critical illness polyneuropathy and myopathy are common in long-term ventilated patients. And you see very often that the diaphragm doesn't function. And this leads to fatigue or non-venability. So how do you look for it? There are two things. One is to look for diaphragmatic thickening during inspiration. I don't have slides right now. Previously, in fact, I used to show this, but due to paucity of time, I can't. You look for diaphragmatic thickening with inspiration, and it should be more than 20% of baseline thickness. That is one. And secondly, the extent to which the diaphragm moves during inspiration, which is called diaphragmatic excursion. So you look at these two things. Diaphragmatic excursion should be more than 20 millimeters or 2 centimeters. The diaphragmatic thickening should be more than 20%. If you don't see these optimal measurements, it indicates significant diaphragmatic dysfunction. And I remember we had a patient some time ago who just failed to wean after a long time on ventilation for presumed pneumonia. And it so happened that when we checked his diaphragm, there was hardly any diaphragmatic excursion. And he turned out to be myasthenia, which had failed to diagnose in the first instance. So critical illness, polyneuropathy, myopathy, diaphragmatic dysfunction, pulmonary edema during weaning, collapse during weaning, all these things are typically what you would look for in patients who fail to wean.
Thank you, sir.
Mahesh, go ahead with questions from the audience.
Yeah.
There are many questions that simply tells us that they are with us.
Correct. So I've got a question for Dr. Chatterjee. When you're doing all these various different hemodynamic calculations, and sometimes when you do it by different techniques and they don't match, what do you think is happening? Why does it happen? Say sometimes, for example, there's a question on stroke volume. Somebody's asking, when I do stroke volume using VTI and LVOT versus the Simpson's method, why do they not match? Where do you think the errors are happening?
While measuring the stroke volume, we have to be very careful while taking the measurement of the diameter, because any error in taking the measurement of diameter will get squared. So that is one point we have to be very, very careful to take the diameter of LVOT or RVOT, wherever we are measuring the stroke volume. We have to be very careful, especially for RVOT. It's a very notorious structure. It changes its shape during the systole. And so we have to be very, very careful to put it exactly in the RVOT. LVOT is not a problem, not much a problem, because we zoomed it and then we measured the diameter. So that is one factor. And as you said, modified Simpson, often we are not in the proper four-chamber view, proper apical four-chamber or mid-esophageal four-chamber. view, if the LV apex is foreshortened, we'll not get the exact value of ejection fraction. The whole modified Simpson is, faulty then, if it is a foreshortened four-chamber view. So these are the points we have to be very, very careful.
Another question is for ERO estimation. If the regurgitant jet is very eccentric, will that have an impact on the measurements?
Yes, the measurement of ERO is not applicable when the jet is eccentric. We apply this PISA method when the jet is central. See, for eccentric jet, it's always good to go by vena contractor rather than PISA. Eccentric jet, the PISA is a problem. So to measure the ERO is a problem.
Thank you. This is another question from Dr. Sushanta Bhoi, and it's a very interesting one. What's the correlation of IVC diameter and central venous pressure measurements in a patient who is undergoing IPPV? We know very well it works in non-intubated patients.
The patients who are in ventilators?
Yes.
Well, yes, there are various studies regarding this, whether there is any significant relationship between the IVC diameter and the CVP in a mechanical ventilated patient. But then some of the studies have shown that, yes, some relation is there, but most of the studies have shown that there is no relation. One study was done by Dr. Arthur and his colleagues. He has shown some good relations between the CVP and the IVC diameter in a patient with mechanical ventilator, but most of the studies have shown that there is no significant relationship. So we don't measure the IVC diameter and its collapsibility when the patient is in ventilator. We go by CVP.
Yeah, exactly.
There are some papers from Frenchman Viard Baron, who has actually done studies, and they've found that the SVC diameter is probably a better indicator of volume status in an intubated ventilated patient as opposed to the IVC. IVC is very good for non-intubated spontaneously breathing patients, but SVC is better for intubated patients.
Yes, that is very easy to look at the SVC also from the suprasternal. Yeah.
But the recommendation for...
Anyone from the panelists want to share about this knowledge?
But the recommendation for right ventricular systolic pressure measurement during intraoperatively, we had to take the CVP, direct CVP measurement from the CVP catheter, because mechanical ventilation can interfere with IVC collapsibility. So IVC collapsibility is not a good method intraoperatively, but in a spontaneously breathing patient, that can be used.
Thank you.
Moving to another question from Dr. Abhijit to Dr. Devika, is about eccentricity of the jet again. In ischemic mitral regurg, is the eccentricity of the jet is taken as a severity of the lesion?
Yes, any wall-hugging jet is considered to be severe unless proven otherwise. So eccentric wall-hugging jet is always significant. We have to be very, very careful because the momentum is lost and we only see the edge of the regurgitation. We can't really see the entire mitral regurgitation jet like we see in the central jet. Eccentric jet is usually considered to be severe unless proven otherwise.
I think it is known as coagulation, isn't it?
Yes.
Mahesh, please go ahead.
Okay. Rajesh, yeah, you want to say something?
I just want to make a comment and a request, comment to Dr. Kumar on his presentation of epicardial echo. Dr. Kumar, do you normally do yourself, the anesthesiologist does the epicardial, or sometimes the surgeon also do it?
No, it's in our institute, we've trained a physician assistant to do the surgical manipulation, and the anesthesiologist stays with the machine. So she knows where to keep the probe, because most of the times we find the problem is where you keep the probe is most important in epicardial echo. So we've trained her to get these 7 views in a sequence, like we do T in a sequence. We've trained her to do these 7 views in a sequence, so that we are with the echo machine and we are hands-free. It makes life easier for us.
And just so in continuation of that, we are lucky that we have a Dr. O.P. Yadav with us, who's representing the surgeons and a collaboration with the Surgeon Society and our Anesthesia Society. Dr. Yadav, you can unmute yourself. I'll be requesting you to give your opinion on that. And especially you being the chief editor of the Surgeons Journal, I would request you to publish more on epicardial or echo papers in your journal so that the surgeons get interested into it. Because if the surgeons can do it, all the draping and the sterilization and other issues are well taken care of. And we people can handle the machine and the surgeon can do the epicardial echo. So if you publish more papers on the epicardial echo in your journal, probably more and more surgeons will be interested to learn this technique. Your opinion, sir?
Well, you have said it all. I mean, all I can say is ditto. But, you know, I belong to the vintage of 1970s and 80s when I trained. At that time, there was no transesophageal. And in fact, epicardial echoes were what we were doing that time. And we were placing the probes. We were doing basic 4 views that time. But now that's become more sophisticated. So, and as an association, we are suitably, as I told, seized of the importance of echocardiography. And we really are extremely thankful to your association for having tied with our IICTS, that the Indian Association of Thoracic Cardiovascular Surgeons, for holding those courses for all our cardiac surgeons to learn the basics. And in fact, for the last 5-7 years, we've been attending your tutorials. I mean, you have been teaching us so much of it through various online platforms. And we appreciate you and Dr. Murli's contribution towards this venture. And we're really excited about it when we put out that who's going to join. I mean, Hiremath had a tough time shorting out the list from hundreds. So thanks a lot for helping us out and teaching us. And I'm suitably seized, I tell you today, how lovely you guys are as teachers. I tell you, the quality of presentations are much better than when we, the surgeons, present in our conferences. We may be good technicians, but we are not good teachers. We are not good teachers, half as good as you guys are. So my salute to you and thanks for helping us out.
Rajesh, if you give probe in surgeon's hands, we will be finished. So be careful.
No, ma'am. No. This is what I want to tell you. No, I don't think anyone
we should not compete. We should complement each other.
Yes.
Yeah.
That's like, yeah.
That you keep reminding all the time.
The screen is with us, so not to worry.
So moving on, I've got a question for Dr. Kumar. Again, is there any role for 3D echo probes in epicardial echo?
Yeah, I think we do have now 3D echo probes, transthoracic echo probes. And yes, the way forward is 3D echocardiography, especially in pediatrics. But I do not have any personal experience with 3D epicardial echo.
There is one question from Shashikan Manikappa from Australia. This is for Sandeep. Do you use safety wedge to enhance safety in pulmonary catheter?
No personal experience with that, ma'am. But safety wedge generally has a pressure release valve so that it can actually prevent the over distension of the balloon. Suppose you're having a balloon which is in the large pulmonary artery and it suddenly migrates into a smaller pulmonary artery. There's every chance that it could actually damage it. If you have a safety wedge, it actually prevents that by decreasing the pressure in that balloon. No personal experience with that. We do not use it.
Anyone from the panel want to add anything more to this, because this is important? Shashi must be, he will be able to guide us later on. Mahesh.
So there's an interesting question from Pooja Natarajan. She asks whether any of the panelists, the faculty members have had any experience with TE for visualizing the spinal cord? I have tried, I couldn't see anything.
I think the views which were described for this was, if I vaguely remember, I think we'll have to go to the descending thoracic aorta and then turn to the left to look at the spinal cord pulsatility, basically, using the intervertebral foramen as your ultrasound window. As cardiac anesthetist, I don't think we would do that regularly, but I've just heard this. I don't have any personal experience.
We in Newcastle, we do tend to do descending thoracoabdominal aneurysms, not very often, thankfully, because TVAR has now taken most of our work. And I have tried hard to look for, sometimes you can see the descending thoracic aorta and blood vessels coming out from it, but that's the best I've seen. I failed miserably, to be very honest. Anybody else with any other comments on it? No, Pooja, I think probably something for you to take up and run with it.
A question from Richa Malik to Dr. Sandeep, I think. Problems of pulmonary artery catheterization when you insert it from left side, IJV, or from femoral vein. Many times we do have to go on the left side.
Yes, ma'am. We can do it, ma'am, but as we know that the right IJV is more in line with the right atrium, and also whereas the left IJV, it takes a more of a curve. But since it's a balloon-tipped catheter and it actually goes along the flow, you can actually negotiate it, but it will be a little more of a problem. And next thing is we are more comfortable with a few numbers apart from the pressures. We know that 20 to 30 centimeters, we should be getting into the RA, then the RV, etc. If you're going from a new pathway, it may be a little difficult in the initial stages and you may be confused whether you're there or not there. And if you see the femoral artery, yes, we can go through that. But one problem will be from the IVC to negotiate it into the tricuspid valve, it may be a little difficult. We are not in the cath lab under fluoroscopy guidance, so we actually do not know how exactly it is going to go. And next thing is that there will be a problem with infection when you're going to the femoral route. The pulmonary artery catheter is there to stay for some time. It is not that you're going to put it and again take it out immediately. So it's going to stay for some time. So I would preferably not want something to go from the femoral right into my pulmonary artery.
Thank you. Nice.
So there's a question from one of our pediatric colleagues. This is for Dr. Chacko. You mentioned the calculation of pleural effusion volume approximately by using the interpleural distance and multiplying it by 20. Is this valid in a pediatric population, or if not, are there any other ways of looking at estimating pleural effusions volume in pediatric population?
Yeah, I am personally not experienced with pediatric ultrasonography, but I think the measurement should hold true even in kids. The distance as well as the volume measurement based on the difference between the distance between the vessel and the parietal pleura multiplied by 20 in millimeters should give the volume, because it should hold true. Yeah.
So Rajesh, can we go for some 1 or 2 questions?
I think just last question you can take and then we can wind up. It's already around 8:30.
Okay, Dr. Narendra Menon, he wants to ask Dr. Kumar, what is the gain for epicardial echo?
Usually we start with a gain of around 50 and then we go up around, usually when we do epicardial echo, we've seen that we need to use a higher gain. These are high frequency, high resolution probes. So you need to go up on the gain to at least 60, 70 sometimes to get good quality images. So I think when you start at a default gain of 50 and think you have to go up on the gain to get good quality images. That would be my recommendation.
He has one more question with the same question. Can we use TE probe in the pericardium as one cannot insert the probe in esophagus?
Yes, we have done that also. We've used the pericardial, we used the TE probe over the heart. there are advantages and disadvantages. What is the advantage? You just leave the probe on the RV myocardial surface and you can change the angles and you can get multiple views. One. The issue is, the disadvantage is, the pediatric transthoracic probes have frequencies from around 8 to 12 to around 5 to 8, very high frequencies. So you get excellent resolution images with the transthoracic probes. You would not be getting the same resolution images with the TEE probes. But yes, the TEE probe can be used over the heart. You just have to ensure the sterility.
Thank you.
Thank you. I have a question for Naman now, and actually a comment and a question both. I would like to play devil's advocate here. Now, we are, at least in the UK and Europe, and I know this because I did a quick survey with some of my EACTA subcommittee colleagues. We are, at the moment, if a patient is proven to be COVID negative, tested, within 3 days before surgery, we are not doing any enhanced PPE at the moment. And we just wear a normal face mask and we go about doing TOE as we were doing pre-COVID era. Now, the guidelines from the ASC say you treat each and every patient as a COVID positive, even if you know that the result is negative. So the question is, are we sort of being a bit paranoid and going for the full enhanced PPE, or is it time now to sort of, because we know a little bit more about the disease process, is it time now to say, you know what, if I think the risk is low in this particular patient, for me personally, am I okay to just wear a mask, which is what I'm doing at the moment? Unmute.
Unmute yourself.
Yeah, sorry, and nice meeting you all after a long time. I hope everyone is safe. Basically, if you take my call, I would still not consider it as a paranoid, but would like to take a very strict precautions, because if I tell our statistics in last 15 days, our 5 patients, I'm talking about last 15 days, our 5 patients with previous day operation theaters negative, both HRCT as well as the RT-PCR, third post-operative day, they behave differently. Behave differently means the hemodynamic instability, along with, so we have sent the flu profiles, the CRP went up, their ferritin level went up, D-dimers went up. We have sent their patient for the RT-PCR, and then they found to be the third correct score. We have these 5 patients in last month. I'm talking about these 15 days, but total over last month, we had these 5 patients who had done negative in just the day before. And it is very difficult to convince relative then. Now for us, we have to take care every single patient. Of course, I don't say PP kit means the standard PP kit. We have reformed our different PP kit. Like we wear the gowns is not the standard PP kit because it's too difficult to be there in the operation theaters all throughout 4, 5 hours, 6 hours. And so what we have designed our own different way of the gowns, the disposable gowns with a good ventilations, with having the 2 masks 95 over the surgical mask with a face shield when you are in the operation theaters, with the 2 gloves. But we remain very careful. Even in the intensive care unit also, we have provided such same quality of PPE to our staff, because we don't know, like we get a patient with a negative reports and this patient comes out with a positive day 3. Many of the times this patient history is very important, from which area they are coming, through which they pass it, who are the relatives. And like we have made a very nice filter scrutinized area in emergency room and admission room, where patient's relative is been kept across the certain barriers and take a complete full history of the patient's geography and from where they are coming. And then we just scrutinize, we send the RT-PCR and HRCT both the previous day. Of course, we still consider 5 days or 8 days apart actually. Not exactly the 3rd day which is recommended, but at least for within a week it should be done. Otherwise, at least we repeat the HRCT for all those patients before the surgery. And that's what Of course, people may consider paranoid, but we want to be more careful because we got into trouble actually. And I think if I tell you myself, we read the patient, you know, in cardiac surgery, patient comes with a heart failure and breathlessness. Patient ejection fraction, I read the transthoracic, and I did the transthoracic and found this patient having ejection fraction of 35 to 40%. And the surgeon asked me, should we do the valve repair for this patient? Because he asked me for doing transthoracic for all his valve interventions. And I said, yes, he needs to be admitted with the full PP kit. I had 5 patients in OPD without any fever, without nose, throat symptoms, and turned out to be the positive after admissions. So I'm real scared. And our hospital, once I got it, our hospital has changed the protocol, and then we are now very much strict. So we have opened up our second setup where we just transfer all those patients who turn out to be the positive. But yes, every institution has their different protocols to, and looking forward to be about it. But this is what I feel.
Thank you, Daman. I agree with you. I was just playing devil's advocate. I mean, we are relaxing in UK, but I think I think it has to be region specific. If you have got if the prevalence of the disease is quite high, I think you'll have to take all these precautions and even more. And I cannot stress how easy it is to catch this virus. I think Rajesh was probably trying to say to us that it's time for us to go and finish this. So on that note, I would like to thank all the panelists, the moderator, my co-moderator, all the people who have asked questions, and obviously the organizers and our sponsor for having such a nice meeting. Stay safe, stay strong, and I hope to see you guys soon in person. Thank you. Rajesh, is there anything else you would like to add?
Thanks, Mahesh. And before we request Dr. Murli for final goodbye for the day, I just present the statistics. We were on air for 237 minutes live without any interruption, without any hiccups. All our presenters finished their talk in time. Our e-poster session was within time, absolutely well managed by Dr. Prabhat and his colleagues. And may I tell you how many people were online with us? I think I'll go beyond anybody's guess. There were total 7,718 people online with us on the Medinet platform. 7,718 people online with us today. And courtesy, I'm thankful to the Medinet people, and from their side, the Kanchan was online. And obviously, all credit goes to Dr. Murli for a smooth run, and I request him to conclude the session for the day.
Thank you very much, Rajesh, for the kind words, and I'm extremely grateful. And in fact, I have no words to thank the panelists and the moderators and the faculty who have given world-class deliberations. And I would like to thank the NH and IACTA for supporting this activity. I'm extremely grateful. And regarding the credit goes to the team members, you in particular, the Medinet and my support staff here, your support staff here, and all the faculty members who have contributed such excellent deliberation. It goes to them. I'm only a part of the whole team. And thank you very much. And we will see you tomorrow at 4:30 in the afternoon for a similar proceedings tomorrow. Paper presentations followed by 5 talks. Again, top class talks I'm expecting. So please join us tomorrow. And Venkatesh is telling me that the virtual dinner is ready. Please join us for the virtual dinner, and then we go to sleep. Rajesh, you want to say something?
Yeah. Tomorrow we are going to declare the results for Golden Fate and the e-posters also, right, in the middle of the session. So all the participants be ready, and let's see who gets the prize for the best paper presentation.
Absolutely, absolutely. Thank you once again. Thank you. I would like to name all of you, but I'll just Mahesh Prabhu, Sanjeevani Namdar, Devika Chatterjee, Jose Chako, Kumar, Sandeep Garre, Naman Shastri, especially Yadav OP, Uday Gandhe. Thank you, Uday, for coming. Unni Krishnan, Sriman Narayana, Rahul Guha, Vishwas, all of you have helped us to get some material out of this meeting. Prabhat Tiwari, Manish Mishra, and Satyajit Mishra were also there with us. Thank you once again, and we see you tomorrow, same time, same place. Thank you so much.
Thanks a lot.
Thank you very much.